glad you can join us this afternoon. So for those of you who don't know me, I'm Nikki Grandorge, the Leadership and Communities Manager and National Coordinator of Women in Wine. And we're delighted to bring you our 6th webinar in this series. And today we're going to be talking about the menopause. It's a topic previously been a bit taboo, but something we very much need to talk about more freely and learn more about. We're very lucky to have here today Dr. Anju Basu, who is an expert in this field and women's health. So I'm sure we're going to learn a lot. So please put any questions you have in the chat. And I'll hand you over to Dr. Jo Cribb, our chair, who is going to introduce Anju. Thank you.
Thanks, Nikki, and what a fantastic space we can create today. This is a topic very, very, very close to my heart and my HRT patch, but that's another thing we can talk about how we go forward. But I'm really pleased that Anju has come here. She comes very highly recommended, and I know she has a passion for women's health and that we create spaces where we can talk about it. So Anju is one of the leading gynecologists specialising in a range of things, urogynecology, I probably didn't say that right, and surgery that creates the least invasive. She's the only gynecologist offering robotic surgery, but treats a wide range of gynecological conditions across all age spectrums. But she's incredibly passionate about patient and doctor communication, and particularly empowering women with knowledge about their health. And that sounds like an amazing way to lead into your presentation. Anju, thank you so much for coming here and talking about this topic that impacts so many of us, but yet we don't always talk about it.
Thank you, Jo, for that introduction, and thank you, Nikki. It certainly is a very, very important topic. Just absolutely every woman who's born is going to go through this. At what severity and what kind of problems women will experience, they vary, but everyone goes through menopause. Anybody who has a start of period will also have the period's finish and its consequences. So I'm going to, sorry, I'll just try and see if I can, yeah. So I'm going to talk broadly about menopause and then talk about the symptoms of menopause, what other things that happen in our body follow during the transition period, as well as menopause and postmenopause, and then what are our treatment options to help women with this. I wouldn't call it a condition because it's a natural time of a woman's life. So basically what it is when our periods completely stop and they don't return for 12 months, that's when we say we've gone into menopause. There is a huge time of many years sometimes for women when periods start becoming very irregular. And they may not become irregular. Women may still have regular periods, but they start getting symptoms which sound to them like menopausal symptoms that their mothers or their sisters or friends have talked about. And that period is called perimenopause. So menopause is a time in our life when our periods completely stop and they never return. And when they don't return for 12 months, we say we are menopausal. It's an end of the reproductive life, i.e. we cannot get pregnant after that. So what happens in the body is that we are all born with a finite number of follicles in our ovaries. So in our body, structurally, and I might be talking very simplistically as well, but I just thought I will go to the very basics and talk about ovaries in general. So we have 2 ovaries. We are all born with 2 ovaries. We are born with X number of follicles. We do not make any more. So before we are even born, our follicle count drops down. And then we get to our puberty, it drops down further. And slowly we start using these follicles as we get into puberty and start having a period, and eventually the follicle count will drop the ovarian function will start declining, and ovaries produce mainly three hormones: estrogen, progesterone, and testosterone. And it's the estrogen that has the main effect in terms of symptoms that are related to perimenopause or menopause. So as the estrogen starts declining, we start feeling all those symptoms. So the natural age of menopause is anywhere between 45 and 51, and the mean age in our part of the world is 45 to 55, and the mean age is 51. Any woman that goes into menopause between the ages of 40 and 45, we say they've gone into early menopause. That is of concern because they have larger number of years to put up with symptoms that are obvious to them. But don't forget the things that are not obvious to us, which I'm going to talk about as well. And then women who go into menopause prior to 40, we say that is premature menopause, or it's called primary ovarian insufficiency, so to speak, in the sense that the ovaries somehow are not functioning properly even before the age of 40, and that is more of a condition rather than a natural phase in our life. But then again, there are also some women who will go into menopause as a result of surgery, what we call surgical menopause, which means their ovaries have been removed for whatever reasons. They could have had a big growth on their ovaries, they could have had ovarian cancer or some other condition that required their ovaries to be removed. Or they have had chemotherapy for some a totally non-gynecological condition, or pelvic radiotherapy for whatever cancer, and that can also put them in menopause earlier than their designed age. So as I said, that we are all born with X number of finite follicles. These are what we call oocytes or egg cells, which basically what they are is that they are follicles that are designed to mature in each menstrual cycle to produce an egg. And that, as a result, produces estrogen and progesterone. And that is, there's a cyclical pattern that this hormone production happens each month for women. And there is a gradual reduction in the number of these follicles from the age of puberty up until we get to about 40, and after 40 it starts declining rapidly. And not only the number declines, but the quality also declines. So we use up all the good ones first, and then we start using all the ones that are not all that good. So therefore there is a drop in estrogen levels. It's not a very good decline, like as if it does take a nosedive after 35, but it's not dropping down in a sort of called linear way. It fluctuates a lot, and women go through this roller coaster ride because sometimes it's really up, sometimes it's really down, and the symptoms that we experience are all to do with the fact that these hormone levels are up and down. You could be having an absolutely normal, regular periods, and you still are going into, you're still in perimenopause. And about 30% of women, they will start becoming aware of mild symptoms from mid to late 30s while they're having regular periods. So they're nowhere even close to menopause, but they might start experiencing these mild symptoms. Sometimes they're aware of it, sometimes they don't realize it till later, but they start happening because of all those fluctuations. And this fluctuation becomes significantly more in 40s. And eventually the ovaries, they run out of their follicles or juice, and then we don't have any estrogen or progesterone, and hence we start noticing the symptoms more significantly. The transition phase to that line in sand when the periods are completely stopping is perimenopause. That period can be very variable. So it could be, on an average, it could be up to 4 years before the periods completely stop. And during this time, there's huge fluctuation in hormones. The ovaries are sometimes functioning really well, sometimes not. The symptoms of menopause the most common symptom that everybody knows and talks about being hot flushes, but there are many others that I'm going to talk about as well as the menstrual irregularities, which means that from having an absolutely normal cycle, you go into either having short cycles or longer cycles, and sometimes prolonged bleeding, and sometimes even heavy bleeding. Now, there can be other reasons for it as well, and we only assume that this is perimenopause when we've ruled out all the other causes. And 40 to 50% of women will start experiencing some vaginal dryness and change in lubrication in their vagina 4 to 5 years before their period. Now, we are very happy to talk about hot flushes and night sweats, but we are never happy to talk about how our vagina feels, whether it feels dry, whether it feels irritated, whether there is any itching, or whether we're rushing to the toilet all the time, we have sense of urgency, we go more frequently, and we're really not passing much urine. These symptoms are quite common, but they're not talked about very much. And what about the blood test? So women often will tell us, can you do a blood test to tell me whether I'm in menopause or not? If I could do that blood test, that would make everybody's life really easy. However, there are no such blood tests. So basically what we measure is, there are 3 hormones we measure. One is called estrogen or estradiol, which is a hormone that our ovary is producing. Then we measure things like FSH and LH. And these are indirect measures of ovarian function. But because there's huge fluctuation from day to day, during the day itself, you could measure it in the morning and afternoon, you can get a totally different result. And it's not like having a hemoglobin or your blood count or your thyroid hormone levels, which is not going to change in a hurry unless something else happens in the body. These hormones notoriously change significantly. So all you're going to get is a snapshot in time. So it might be totally normal, but you're having perimenopausal symptoms. So you look like, well, I'm having all these symptoms. You're telling me my hormone levels are normal. So what's wrong with me? But that's why they're not useful at all. And they can be normal, and you can have, you could be drenched in sweat and it's still normal. So we don't advocate for blood tests. There are very, very few indications for blood tests in this scenario. And one of the common ones would be if someone comes to us, say in their 30s, and they're saying, well, my periods, something's changing with my periods. And I haven't had babies and I'm worried. We might do that. And when we do these blood tests, we will do them quite frequently to work out what's happening. So looking at a pattern. There's another blood test called anti-Mullerian hormone, which is being talked about quite a lot. It's mainly used in fertility setting, but there are some studies that have been done which say that it is a direct indicator of egg reserve, and there are some studies that show that it reaches near 0 3 to 5 years before the periods stop completely. So it can be useful in some scenarios, but even if it is 0, you still may not have gone into menopause, because it can reach 0 several years prior to reaching menopause, and you could be having regular periods. So blood tests are really not of much help at all. It's the story. Everything is in the story. Like many things in medicine, it's the story that the person tells us and the pattern that we are recognizing. That is more important than any of the tests, especially in this regard. So age of menopause can be determined by several factors. Could be genetics. If your mom has gone into menopause at age 48, there's possibility that you might also go into menopause at the same age. There are some studies that have compared women that are Japanese American and European Americans. They found that Japanese Americans, they go into menopause later than the European counterparts. Hispanics go into menopause earlier than the European counterparts. So there could be some genetics and ethnicity in play as well. And there are lots of studies done to look at women who do night shift work over a long period of time, there is some evidence that they go into menopause earlier. Now, what we don't understand is what's the real reason behind it. It could be to do with the fact that they are sleeping at different times. It could also be to do with the fact that there are typically these kind of works have higher stresses, like for example, nurses and doctors. So or police women. So there might be to do with one of those factors. And women who heavily smoke are also likely to go into menopause early. Not only that, they also have significantly more symptoms than women who don't. So then, okay, well, we know this is something that's going to happen to every single woman who was ever born and ever had a period. Their periods will eventually stop. So if they do stop, what kind of problems do they bring with it? Well, there are 4 core symptoms. Hot flushes and night sweats are the most commonly reported, and women who will report them, 2/3 of them will say that the symptoms are moderate to severe. Then there is sleep disturbance, which can be either due to hot flushes and night sweats, and sometimes it can be, it's not to do with night sweats at all, just that their sleep is, they can fall asleep, but then they wake up and then they can't go back to sleep. And there's a variety of patterns of sleep disturbance that it can come with as well. Vaginal dryness and painful intercourse. 25 to 45% of women after menopause will be affected. So what happens initially is that you'll start experiencing hot flushes, night sweats, sleep disturbance, some change in your mood. You may not notice anything to do with vaginal dryness or painful intercourse for several years afterwards. But once it starts, the thing about that particular symptom is that it's only going to get worse. So it must be addressed at the point when it happens. Whereas with other symptoms, they eventually get better. So they are at their worst in the first few years in perimenopause and menopause, and then gradually these symptoms will get better, whereas vaginal dryness, bladder symptoms of bladder irritability, which means you're going very frequently, or you have a sense of urgency, and you can't hold on, that those kind of symptoms, once they start, they will get worse, and they can be very easily addressed, and I'll talk about that as well. And mood swings. Now, there is an increase in rates of depression and anxiety in women during this period. Now, it could be very subtle, and women themselves may not recognize it, and it could be very transient, and they don't feel it, and it gets better, and so they think, well, it didn't really occur to them. But then there are some women who will be quite significantly affected, and we also know that there is women who have previously had depression or anxiety, or if they have had postnatal depression, they are more likely to have their mood affected during this period. They also, there will be women who have new onset depression or anxiety. They've never had a problem in their life, and suddenly they notice that they have started becoming anxious. It's very inconvenient because this is the prime time of our lives. This is when we are at the peak of our career. Things have settled financially. We've started to become more independent and better off, and all of these things come about as we've achieved good times in our lives. So it's about being aware that it is normal, but there are things we can do about it. We can do something about it. Then there are, of course, achy joints, muscle aches, fatigue. Women will often say, I'm talking to somebody and then I suddenly forget, what was I saying? Or I know this person for 10 years and I cannot remember their name. Now, the good news about that is that we are not alone in this. Men have the same problem as well. It's just that they may not talk about it and they might be able to hide it better. But if you look at studies, women do better than men if you control for age. So say, for example, if you do a study on 50-year-old men and women, with cognitive abilities and tasks that require cognitive abilities, we perform significantly better than men. So yes, it does happen, but we are not worse off than them. Then there is something called brain fog. Brain fog is essentially, well, I can't concentrate. I'm having difficulty coming to conclusions quickly, or I go into a room wanting to do something and then I've forgotten what it was. And there are small changes in our hair. The hair, some women will notice hair loss, hair thinning, skin changes, the collagen content in the skin reduces. That results in dryness of the skin, wrinkles, as well as thinning of the skin. Then there's changes in libido. Libido in women is very, very complex. It's not the same as libido in men, and menopause has a role to play, but there are often multiple other things as well. And if you are experiencing change in libido, it is really important to talk to your doctor about it as well. And then often women will talk about change in their weight. They'll say, I'm doing exactly the same amount of exercise, I'm eating, if not the same, I'm eating better, but I'm still gaining weight. The change in weight is to do with our age, our lifestyle, and a little bit about the menopausal hormones. We like to believe that it's all to do with menopausal hormones, but multiple studies have shown that that's not the case. However, what menopause does to us, or in terms of our estrogen levels dropping, is that we tend to collect more weight around the abdominal area, which is not the nice place to collect it around, both for appearance as well as for health. So that's what lack of estrogen does to us. So then the next question is, how long will these beautiful, lovely symptoms that we collect around this time will last? Well, nobody knows. For some women, they will last for a short period of time. They will be really intense. And if I just go back to that slide, 1 in 4 women will say, I had no symptoms at all. It might be that they did have, but it was so mild that they didn't actually stop to think about it because it didn't affect them very much. 1 in 4, it will be severe. They cannot function. And then the rest, 50%, will be in between, have some symptoms. They come and go. I can manage this. And in terms of how long, they can start in perimenopausal period. So that can be a few years before your last period, and then they can go on for some years. Good news, it's really worse at the start and things get better as time goes by. There's only a small proportion of women who will continue having these symptoms for 10 to 20 years. But majority will have the symptoms initially and then they will get better. So how else does it affect? So all of those symptoms, of course, they're not very pleasant. They affect our quality of life. They affect our work. They affect our relationships, our general life and enjoyment of life. So we notice those things. But then there are other things that are happening in our body around this time due to lack of estrogen that we don't even realize. And that is there's a bone loss that is happening. So all through our life, we form bone and some bone mass will be destroyed. But that process is evened out all through our lives. But after a certain stage in life, we will start losing bone. And that becomes more prominent around menopause. And that's why we talk about bone health around menopause. What can we do about it? Doing regular exercise, which is weight bearing. And I think I've got a slide, so I will go into that a little bit later. And then there is, it can affect our heart health. So we are at increased risk of cardiovascular disease, such as a heart attack, angina, or stroke, or even developing a clot. So that's affecting our heart. Now, it's not going to happen to every woman. We are just at an increased risk at that stage of our life, as opposed to when we are not menopausal. So osteopenia or bone thinning is different to osteoarthritis, but we are also prone to osteoarthritis after menopause. Menopause will, as I said earlier, it's not going to make us gain weight, but it will shift our fat distribution, and it'll all go into the abdomen. So whatever weight we are piling on will go all into the abdomen, as opposed to other parts of the body, sadly. And then, of course, there are skin changes. So those are all the things that can happen. Some things we are very aware of, some things are happening silently, like our bone health, heart health, joint health, our balance, our muscle mass goes down, our weight, there's a shift in our fat distribution and skin changes. These are silently happening. Some of them we might notice because of the appearance of the skin. And then, so what can we do about this? Of course, with regards to the body weight and body distribution, so quite a common, I thought I'll put up a slide separately for this, because this is quite a common thing that women will talk about, because suddenly they have seen a change and they wonder what it is and whether something can be tweaked. Well, good news is, yes, we can do something about it. It's mainly to do with, as I said earlier, it's mainly to do with lifestyle factors and the general aging. It happens to men as well, but our hormones do play some part in that. And what can we do for ourselves? We need to focus more on healthy eating than we ever did in our 20s or 30s. We can get away with eating lots of yummy food in our 20s and 30s, but we won't get away easily at this time in life. Having good sleep habit, following, all those good sleeping habits that people talk about. Don't use a screen. Try not to stimulate your brain too much before going to sleep. All of those things really work. And the better sleep we have a better ability to cope with the symptoms that come with menopause as well. Exercise and regular exercise can be anything. It can be walking, it can be swimming, it can be very light weights. You don't have to join a gym. You don't have to do, 2 hours of exercise. Nobody has got that kind of time. But if we can do 3 to 4 days of some good amount of moderate weight-bearing exercises like walking, fast walking, jogging, some light weights, that is good for not only symptom control, our weight management, but for our sleep, but more importantly for our bone and for our heart health as well. Smoking, if a woman smokes, I often would say, try looking into either reducing smoking or stopping smoking. The smoking rates have become significantly lower in comparison to even 20-25 years ago. So we find that women are smoking less and less these days than what we used to find. But then again, there is the transition from cigarette smoking to vaping, and I'm not sure. I don't think we can comment on vaping at the moment because there's so little that is known about it. And then I'm going to talk about limiting alcohol to women and wine. So I'm not saying don't drink. I would say limiting it. So 1 standard drink a day is what we would say the limitation, because alcohol can be a trigger for menopausal symptoms as well. And different types of alcohol can be a trigger for different women. So some women will say it's white wine. Some women will say it's the spirits, or some will say it's red wine. And most will say red wine is okay for me. So whatever is your trigger, try to avoid it. And a lot of the times women will also say, oh, I don't sleep very well, therefore I drink a glass at night and that helps me sleep. Well, if it helps you sleep, it's fine. However, there is a reasonable amount of evidence that it actually affects our sleep as well. So you need to be a bit attuned with your own body, and one size doesn't fit all. So if it works for you, have it, but limit it as much as you possibly can. And whichever type of alcohol is your trigger, there are certain types of foods that are triggers, like chili hot food, or sometimes even things like chocolate, white wine. Those would be the triggers. And obesity is also a risk factor for severe menopausal symptoms. So losing weight helps your menopausal symptoms, as well as your bone health, as well as your heart health. And smoking is also one of the risk factors for bone thinning, which means that women who smoke are at a higher risk. And of course, if in addition to menopause, if you've got multiple other risk factors such as obesity, or if you are very thin, or if you have a family history of osteoporosis and you're a heavy smoker, that will all add up your risks. So we've talked about physical activity. It not only helps us maintain our weight, manage our symptoms, has an impact on our bone health. It keeps our muscles strong, so therefore whatever arthritis is happening in the joints, the muscles that are surrounding them, if they are strong, you'll be able your joints can withstand more than if your muscles are weak around it. It improves our balance. And if our balance is good, we won't fall. If we don't fall, we won't have injuries. We won't have our broken bones, because osteopenia, or thinning of the bones, or osteoporosis, is a risk factor for fractures as well. And so we've talked about all of those things. Now, what are the other things we can do apart from lifestyle? We can wear natural fabrics, we can wear them in layers, we can carry a portable fan, and it's quite okay to do that. If it works for you, do it. And I think more and more people in workplaces are becoming, are accepting of this, and they should be accepting, because a lot of women in this age group are in leadership roles. We want to be productive, we want to be efficient, and if it takes to have a phone a fan at our desk, then I don't think that's a big ask at all. So those are some of the lifestyle things we can do, and though they can be easy to put in place, and sometimes it's all about just taking a little bit at a time and say, okay, well, for the next 2 months, I'm going to focus on this, and this is what I'm going to do for myself. This is a natural process, but it's affecting me, and this is what I can do for myself. And then there are other treatment options that we can offer, either as a prescription, but there is also some evidence in favor of complementary treatments. So complementary treatment means that this is not coming from a doctor's prescription, but just be very mindful of what you're reaching out for, because there is some that have been proven to be safe and effective, and some that we don't know enough about, and there's no regulation. So I'm just going to go through that. So targeting treatment options to your symptoms, because the list of symptoms is so big, we want to understand what is it that is affecting you the most, so that we can find the right treatment for you. So there's something called remifemin, which is a plant-based estrogen, black cohosh, which can help hot flushes, but it only helps mild hot flushes. So if you're experiencing mild hot flushes, there is evidence that this works. If you're experiencing mood changes and they are mild, then things like St. John's worts, they help as well. There's very good evidence in favor of hypnosis. You'll have to obviously find the right practitioner, but there is very good evidence that it helps. There's growing body of evidence in favor of acupuncture. Not so much for yoga and mindfulness, but it can help us cope with the severity of the symptoms. It may not help with in comparison to some of the others, but it will help with coping with the symptoms. But just be very mindful of other products that are sold in the market and are marketed as natural products like soy or plant-based estrogen, wild yam creams, compounded progesterone cream, and dong quai. The reason for that is that all of these products have some form of estrogen, and that's why they work for some women. But the problem is we do not have any regulation in terms of production of these. So if you tell me how much estrogen is there in this tablet or a patch or the pellet that you're putting in, I can tell you exactly how much each tablet will have. And there are safety and efficacy studies that have been done on women over periods of time. But sadly, these products, because they are sold as, they are not pharmaceutical products, they're so-called natural products, there's no such regulation for them. So, a 1 centimeter piece of wild yam cream today might have this much of estrogen and tomorrow it might have something else, a totally different dose. So certainly we don't recommend, and I would say just be aware of it. So then if we come to the treatment options that your doctor can prescribe, there are multiple treatment options available. It's not just HRT. HRT is the best in terms of efficacy, and for women who have quite severe symptoms and multiple symptoms, HRT is the one that works for most women. But there are other things that can also help. So there's something called cetirizine. It's an antihistamine. So, you might have heard of things like Loratadine, Loratab. So it's an antihistamine for sneezing or hay fever. So there is some evidence that it actually helps women with hot flushes as well. So it's a very commonly available medication with very little side effects that you could try if the symptoms are mild, and it might help. Then there's something called oxybutynin, which is often prescribed for an irritable bladder. So women who have overactive bladder, frequency, urgency, leakage as a result of that. We quite often use this. This drug has got properties that relaxes the bladder muscle, but also works on other parts of the body. And as a result, it also helps with hot flushes. The only thing, it can give you dry mouth and dry eyes and various other side effects. Some women tolerate it really well. So if you're not keen on HRT or you have risk factors, then there are these drugs that can be used as well. And then there are a group of drugs called SSRIs and SNRIs. So these are things like escitalopram, citalopram, fluoxetine, paroxetine. So they are broadly the antidepressant. But remember, drugs they might be classified as antidepressants, but they're used for multiple indications. They're repurposed once they are produced for multiple variety of conditions. So they are generally effective in about 70% of women as well. Then there are drugs that were originally designed for as painkillers and for epilepsy, like gabapentin and pregabalin. They work in 70% of women as well. Then there's something called clonidine, which is a blood pressure medication, not very commonly used for treating high blood pressure, but we have found that it works for women with hot flushes, typically only who have mild, maybe bordering on moderate symptoms, but doesn't really work for severe symptoms. It comes in the form of a patch, can be changed once a week, comes with very little side effects. So those are all the non-HRT options that you can choose from. Then, of course, there is hormone replacement therapy or menopause hormone therapy, whichever one you want to call it. So it's a combination of estrogen and progestin. So if you have not had a hysterectomy, i.e. removal of the uterus, we will prescribe a combination estrogen and progestin. Estrogen is what we need for the symptoms. Progestin is what we need to protect the lining of the uterus from the harmful effects of estrogen. So women who have had a hysterectomy, they don't need to protect their lining of the uterus, so therefore they don't need the progestin component. So these things, they come in the form of either patches or tablets that have got both of estrogen and progestin, tablets that have estrogen separately, progestin separately. Then you've got estrogen patches, which many women these days know about it because there has been a resurgence of use of HRT, so it's being talked about a lot. There's been a huge supply issue because the demand has significantly gone up in the last 2 to 3 years, and the manufacturers are just not able to cope with the demand. And you know, some women are when we give a prescription, we are only able to prescribe for 3 months, but the pharmacy might give you 2 patches, which is a week's worth, which is annoying. But the problem is that they need to make sure that everybody in the country gets it. So it's kind of rationing it. And then the capsules in the form of utrogestin that is available. And I'll briefly talk about the most commonly used HRT in a minute as well. You can have a patch, which is the estrogen patch, and then you can also have a Mirena. A lot of women have Mirena for heavy periods, and if they're already using a Mirena, we'll say, okay, well, that's quite enough, and you can have a patch. And then there is estrogen gel that is now fully funded in New Zealand, and then the progestin capsules. So there's a variety of different combinations of HRT. Good news, HRT is fully funded in New Zealand. The utrogestin capsules that we are currently fully funded, they used to cost something like $70 to $90 per month for women. So now it's a prescription cost only. And then there is vaginal estrogen creams. It's a different type of estrogen. It's also being applied locally in the vagina, so its absorption into our bloodstream is minuscule. The way I explain it is that it's like applying moisturizer on your skin. It's not going into your bloodstream. Now, some of it is, but very, very little. It's got tons and tons of safety and efficacy data behind it that we feel it is safe to use for women for long periods of time, and also safe to use for some women with breast cancer as well. No, I wouldn't say that everybody, but yeah, most women with breast cancer or previous history of breast cancer can use vaginal estrogen as well. So vaginal estrogen is typically prescribed for women who have vaginal dryness, they have pain during intercourse, they have bladder irritability, they have itching, they start having irritation of vaginal skin, or if they have some discharge or they're prone to getting either bladder infections or vaginal infections. So that's what we would use vaginal estrogen, and it is okay to use it in conjunction with the patches and the progestin that you're using. So what happened to HRT? Well, HRT was happily being prescribed up until 2001, and I very, very clearly remember the day when it hit the news early in the morning, and suddenly we started getting a whole lot of phone calls. Suddenly we had women wanting to go off it, and the story begins with a study that was done in US, which is called the Women's Health Initiative Study. It was designed to look at benefits of HRT in women in their 60s and 70s. We already knew that it has very good benefit for women in their, at the natural age of menopause, which is 45 to 55 and up until 60. So we knew it was safe, we knew it was effective, we knew it is okay to prescribe, but we wanted to know whether it's still okay for women in their 60s and 70s to have it. So that was the purpose of that study. But unfortunately, what happened is that some preliminary results after 5 to 7 years of that study came about, and they didn't get verified. And before they could be verified, they were released to media. And it was all over the news, it was all over the newspaper, and there was absolutely no going back from it. It took 15 years to go back from it. There's been reanalysis of that data. There have been a number of other studies that have been done. and it has been concluded that it is safe for women in perimenopause and entering menopause in their 50s. Sadly, in that study, there were a number of, obviously it was designed for 60s and 70s women, but there were a number of women who have other risk factors. They have heart problems, they were morbidly obese, they had diabetes, they had hypertension or high blood pressure. So they had multiple other risk factors. So we weren't really looking at our average women in their mid to late 40s, mid 40s to mid 50s. We were looking at a different group of women with different problems. So obviously it came up with bad press that it increases the risk of heart attack, stroke, clots in the legs or in the lungs, and breast cancer risk. We know that when used appropriately, it actually reduces the risk of fractures in women, risk of heart disease, risk of bowel cancer, and in younger women entering menopause in their 50s, there is no increased risk of stroke or clots in the legs or in the lungs. So that just leaves us with the breast cancer risk. So with regards to the breast cancer, what we do know from multiple studies that it's not estrogen that increases the risk of breast cancer. It is the progestin component. And it also depends on the type and the length of treatment that is used. So when we talk about type, there are multiple different types of progestins that are available for us to use. In the past, they were the only funded ones or ones that were readily available to us were synthetic progestin. In fact, the bioidentical progestin, which is the utrogestin capsules that are very commonly used nowadays, they weren't even available 20 odd years ago. And when they were available, it was hard to come by, and they definitely were not funded up until I think a year and a half, 2 years ago. So it's the synthetic progestins. When used over a period of 7 years or more, that's what increases the breast cancer risk. What we do know that body identical, which means this is the type of progestin that our body naturally makes, except we are making it in a factory and we are prescribing it. It carries much lower to possibly no risk of breast cancer, so it's safe to use. Of course, if you have had breast cancer, if you have a very strong family history of breast cancer, that's a totally different scenario, and that requires a discussion between your doctor as well as your breast cancer specialist. So how long should one stay on HRT? There is no arbitrary time at all. Each woman is different. You know, they might have intense symptoms for 1 or 2 years and then they don't have any symptoms. You don't need to, because for other things like bone protection, there are other treatment options that are available. It's mainly the symptoms that we want to treat with HRT. And if you have symptoms for 4 years, well, then you need it for 4 years. Or if you have it for 7 years or 10 years and we've tried to wean you off and they keep coming back, then it's about risk and benefit and monitoring. Mostly we would say if you've gone on it for symptoms that are so bothersome that you've reached out to treat it, then stay on it for a year or 2 at least, because you don't want to tease your body, give something good, and then suddenly take it away, because that's just not going to work. And when you go off it, now there's no real studies that have been done, but what we do find is that women who gradually wean themselves off, even if they have some mild symptoms, when they stop HRT, they cope with them much better rather than going cold turkey. You know, suddenly today you are on 100 microgram patches and tomorrow you are on nothing, and you only took it for 6 months. It's just not going to work. And so gradual weaning will help your short-term flare-ups. Your body starts getting used to the thermoregulation that has, you know, your heat regulation that's not working very well. Your body gets used to it, and gradual weaning is much, much kinder than suddenly stopping. So then, so that's all about the symptoms of menopause, what it does to our body, what options we have. But I thought this would be also an opportunity to talk about contraception, because quite often women are obviously still, they are sexually active, they might have new partners, and there are a number of studies that have also shown that women re-partner in this age group as well. So you have new partner and you might require contraception. And we recommend that some sort of contraception is used for a year after the final period, if your final period is after age 50, and if it's under age 50 for 2 years. And that is because you may have stopped your periods, but there might be 1 or 2 follicles left, and you only need 1 to get pregnant. And if you don't want to be pregnant, then use some contraception. I've definitely seen women fall pregnant because they thought that they are in an age group that they certainly cannot get pregnant. So this advice is based on international guidelines. So what are the take-home messages? It will affect all of us in various ways, some much worse than the other. And you know your body better than anybody else. Don't let anyone tell you this is normal and just suck it up. Well, no, I think we shouldn't, yes, it is normal, but if it is affecting us, we are going out and we are more in workforce, we are in leadership roles, we are doing tough jobs. And if we can't sleep at night, we are of no use to anybody. So our quality of life is important. Length of symptoms are variable for every woman. So what's right for me may not be right for you. So we suit what is right for you. And be aware that there are other things that are happening in the body that you also need to work for. So you have a good, not just long life, but also a good life at the end of it all. And there are options available. And HRT is not all bad. You can use it. And weight gain is not just menopause, but our weight shifts to the midsection after menopause, and that's what is more visible to us. That's all I have to say, but I'm very happy to answer any questions.
Thank you, Anjan, for making that so clear and so simple. We'll just see if there's any questions coming in on the chat. But how do you first approach your doctor? Like, how do you start to have these conversations in a way that so that you are taken seriously? We hear all sorts of stories about particularly medical professionals who can be quite dismissive. What advice would you give?
Okay, so first of all, I would say that go with a clear story of what is affecting you and how is it affecting you? How is it different to what it was? And then say, I'm here to discuss what my options are. So that's number one. Number two, you can also look on, we have Australasian Menopause Society. So it's menopause.org.au. It's a very, very good resource. It's got lots of videos on it, and the videos are quite small. So yeah, they're about 5-minute videos. They just talk about different aspects of menopause. So when you go empowered with knowledge, this is what I have recognized in my body. This is what I have read about. I'm here for you to tell me, am I right? Can you help me here? So just be very open. I need help. What help have you got?
Right.
And there are menopause clinics. There are menopause clinics. The sad reality for us is that we do not have enough of them. And another sad reality is that not many GPs do this line of work. So if you really feel your GP is not listening, then maybe go to a menopause clinic. There's a long waiting.
Great.
It's good advice.
There is a question come through on the Q&A. Do you have any thoughts on the use of testosterone?
Yes. Yes, so testosterone, the only indication would be in terms of libido. So if women come to us saying that my libido is affected, we obviously go through finding out what is it that is affecting your libido. Is it relationship issues? Is it pain? Is it the stresses of life? Is it something else that has happened? Is this a younger partner versus older partner issue? So we work out all of that. Then we look at, do you need sexual counseling? And there are sexual health counselors that are available. And then there is, of course, testosterone that is available as well. Testosterone, some women also talk about, I'm very tired, perhaps I could use testosterone for that. It doesn't work, and it's not recommended either. Its sole recommendation is for libido. It comes in the form of a cream. It is available in New Zealand. Is it funded? I'm not sure whether it's funded or not, but it is definitely available. There is monitoring that is required, and the monitoring is based on the blood tests. So we do baseline testosterone levels, then we prescribe, and then we want to see that the levels are not raising very high, because if it is unmonitored and prescribed in large quantities or used in large quantities, that can have disastrous effects as well. So there's quite a lot of monitoring required for it as well.
Okay, great feedback. Thank you. Any other questions from anybody? Doesn't look like it. No. So, well, thank you very much. That was really comprehensive talk about menopause. Yeah, I think that's going to be very, very useful. A lot of people will be taking away a lot from this. Thank you. Jo, did you want to add anything?
No, just to say thank you for all that you do in women's health, and thank you for sharing. You're just an expert. There is so much information that comes at us, and often it's difficult to work out what is right and what is wrong, and we're marketed all these pills that will make us amazing, but I just think you've cut through from your from the research and in the science. So thank you for sharing your wisdom.
Yeah, it's been fantastic. Thank you. Thank you, and have a lovely evening, everybody.
You too. See you.
We'll be in touch. Bye. Bye.